Hello, everyone, and welcome to our webinar. We are Thermo Fisher Scientific, and tonight we want to talk to you about why does COVID-19 testing in K-12 schools still matter? Before we begin, I just want to add a disclaimer that this presentation was recorded on August 23rd, and the content reflects the subject matter that was current based on the record date. Today we have two wonderful speakers talking to you. The first is Mara Aspinall, who's a professor of practice biomedical diagnostics at Arizona State University, and also the managing director at Health Catalysis Group. And Rachel Formosa, who's a senior director, genetic sciences at Thermo Fisher Scientific. Let's get started on our presentation. And first, I'm going to turn it over to Mara.
Thank you. It is great to be here and to have the chance to talk to you about the most important topic, K-12 testing and keeping our kids, our teachers, and our schools safe. I'm going to talk about four topics today. I'm going to start with what I call the GBU, the good, bad, and ugly. Where did we end spring? Where are we going now going forward to keep schools safe? And lastly, school funding options and some examples of successful testing. So when I look at this good, bad, and ugly, first of all, the good. As we know, 60+% of US adults are vaccinated happily, although for sad reasons with Delta, it's growing. 80% of teachers. Just over a third of kids are vaccinated, and vaccines are highly effective, especially against serious disease. But when we look at the bad, you're probably familiar. Cases are up from last summer, and Delta continues to be driving further increases. It's good, lots of people have been vaccinated, but we're still 1/3 of adults and up to 2/3 of kids are not fully vaccinated today. Mitigation measures are coming back a bit, but widely abandoned, particularly in many parts of the country. And then lastly, we know the Delta variant is highly transmissible. Little bit of good news in terms of its disease function, but it has a shorter pre-symptomatic period, 2 days quicker, which means you've got to be able to be testing to be effective. The ugly, all viruses mutate. The longer this goes on, the more dangerous mutations might emerge. And then secondly, we find it very uniquely, 20 to 60% of cases are asymptomatic. So why do I start with the ugly? The making of a variant. You're probably familiar with this, but this is what happens. This is the COVID-19 cell. A random mutation, not a big deal. More mutations, and one of three things happen. It's a variant of note, not a big deal. A variant of interest, starting to be relevant. And then a variant of concern, for which we've had four: alpha, beta, gamma, and delta. And that is where we are today, dealing with the Delta variant of concern. Why is this a concern? Well, these are my 5 questions when you look at COVID-19 and you look at that cell over there, those green stalks, those are the spike proteins. They come out as a spike, and it's those spikes that attach to the internal system of our bodies. 5 questions to ask. Do they make tests accurate? Just a few. Very, very few, and none of the EUA tests. So any test that has an EUA is accurate against Delta. Does it increase cases and death? Unfortunately, it does. Does it make some treatments ineffective? Well, some, particularly antibody tests from people who've recovered from non-Delta. But now there are a lot of people who have recovered from Delta. Vaccine effectiveness, yes, and most importantly, it raises the hurdle for herd immunity, so we need more people vaccinated. And today's an important day, given the FDA gave full approval of the Pfizer vaccine. So that's the first part of ugly. What's the second part? Uniquely with this virus, 20 to 60% of cases are asymptomatic. These are studies with adults, but the same data seems to hold true for kids. A minimum of 19 to 20%, but more likely 40 to 45% of all cases. People feel fine and have no symptoms, but they can still transmit to others. And sadly, what we now know is even fully vaccinated people can transmit this disease. So where does that leave us? There's some real ugly there. So where did we go in the spring of 21? When we look at the spring of 21, the good news is by the time we got into May, there were only 2% of schools that were virtual, and there were the overwhelming majority of schools, 70%, were traditional. We still had 30% who were hybrid, but many of those schools pledged over the summer to go back in person. Did it vary across the country? A little bit. This gives you the map of what it looked like at the end of the last school year. California was the state that has least in person, but many, many states were mostly in person, which is clearly the best way to educate kids. So if you're in that position, we ended spring 21, we are so optimistic. Where do we go from here? And how do all of us help to ensure school COVID safety? I believe there are three different pieces of this: vaccination, mitigation, and confirmation through testing. I'm going to start with vaccination. You're familiar with this, but this takes a look at vaccinated groups and how high a percent they are. And you can see it is clearly a curve up, with those over 70, over 65, and over 80 doing pretty well in the vaccination. And every day these numbers increase. But the bad news here is that COVID is finding new people to infect, certainly the unvaccinated. Now, in the center of the graph, you could see what's happening in Israel. 39 or almost 40% of all new cases in Israel, which is roughly 4 months ahead of us, are indeed kids. If you add the 0 to 9 and go from 0 to 19, 50% of cases are those who are under the age of 19. In the US, happily, it is not that bad. Although 2 weeks ago, 18% of all cases were kids under 18, we call kids. Now children account for 15% of COVID cases. That is certainly a concerning number. Serious cases are still highly rare for kids and rare for the vaccinated, but it's still clearly a cause for concern. So how do you deal with it in a school? Well, let me give you one example in the UK, where they looked at 162 high schools, and they had two different groups, what they called the control group, 76, versus the intervention group, 86 high schools. And when there was an index case, because we know it is clearly possible, particularly in high schools, that you will have somebody positive, the control group sent everybody home. 10 days quarantine. The intervention group said, let's do it differently and let's do daily testing. And what they found was, for the group that had the intervention, 61% fewer days lost by staff and 40% fewer days lost by students, showing that testing can make a very big difference. The number of cases were not very different when adjusted for the size of the population. So no additional outbreaks and fewer days lost. Why is this so important? It's so important now because of Delta. And in the US, as you're probably familiar, Delta and its second cousin, AY3, which is different from Delta Plus, this is a new subsection of Delta, account for 98, 99% of all infections. And do we think it is contagious? Well, it took Alpha 3 months to become the dominant strain. It took Delta 1 month. Not since the very beginning of the pandemic have we had one strain that essentially is all of the US. And you remember we talked about R naught and we thought it was 2 or 3. With Delta, it's 7. One person can infect 7 others. So where do we go from here? If we can't get everyone vaccinated, let's talk about mitigations. I see it as there are 6 mitigations. The top 3 I'm going to submit are not very controversial or difficult to do. Hand washing on a regular basis, cleaning the classroom, and health checks and teaching kids not to sneeze, out into the open. So what are the challenging ones that either cost more money, more challenging to do, or unfortunately, somewhat controversial? And those are surveillance and monitoring, physical distancing, which is very hard in virtually all schools when you've got a full census of kids, and masking. So let's talk about masking. What does the CDC do? You know this is the end of July. The CDC was saying all people, particularly in indoors, should be masking, including fully vaccinated people. For those of us who are vaccinated, this came and it was highly disappointing, but I think we need to respect it. Indoor universal masking for all teachers, staff, students, and visitors. The reality, however, is this isn't going to happen because individual states, districts, and schools are going to choose not to do that. What are the options here? Well, when you look at state by state, you see roughly the same number. About 24% of states are requiring masks and 25% have mask mandates banned. So about 50% of the states are giving local flexibility. So it's a real conundrum as to how you put this together. So what I see is if you look at these mitigations, you try to do as much as possible on the top level. When you get to the bottom level, I think it's ideal to do as much as possible, but if you can't, you got to focus on testing. So let's look at testing. What are the key criteria? It's easy, it's effective, it's accessible, and affordable. And the nice piece about affordable is the federal government pays for it. Testing strategy, you've heard this a lot of times, test sensitivity, specificity, frequency, time to results, logistics, and cost. Those are the key issues. What we see as part of the National Testing Action Program are 3 steps. Starts with step 0, which is initiation testing, particularly when you go back to school or after a holiday or even a long weekend, to test everybody as much as possible. Then work on to asymptomatic screening. The most popular way to do that is pooled PCR testing, and then looking at the positive pools and following up as required. Happily, in the spring semester, it'll be up, but hopefully not too much. There were only 1% of pools that were positive nationwide. So we looked at all the different testing options. I just talked about lab-based pool PCR, 24 to 48 hours. Antigen-based on-site lateral flow, about 30 minutes. There are pros and cons to each type of test, but I'll focus on the pooled PCR testing. How do you do that? Well, I think there are 4 steps here, all about communication, coordinate, and working with the administration to ensure that everybody understands the process. Secondly, testing modality selection, figuring out what you want to do. If it indeed is pooled PCR, setting up the on-site centralized or even sometimes decentralized model, and then you've got to decide on results reporting. If you do this with an antigen test, the processes are essentially the same. Does it work? Well, Mathematica, supported by the Rockefeller Foundation, did a model to look at in-school infections and found that regardless of where you start, regular testing reduces in-school infections by 50%. And does it work in terms of confidence? Well, when you see, this is the Wellesley Public School System in Massachusetts, look at these numbers. Before testing, about 14% of teachers and staff felt confident going back, 82% afterwards. Just over 30% for parents, 85% afterwards. Testing can help make people feel safer. But does it work? Well, we have found that the school prevalence rates are about 10 times lower than the community rates. And we've seen this in rural, urban, and suburban settings. In New York City, 0.5 compared to 5. In Colorado, 0.5 compared to 4% positive rate across the state. El Paso, Texas, at the height of the pandemic there, had a community rate of 10%. Their positive rate in the school was 1%. Schools have lower prevalence rate, but unfortunately it's not 0. So does this work? I'm not going to go through all of these slides. We're happy to make them available for you. But example after example in Massachusetts, Baltimore, Delaware, California, Minnesota, and Ohio schools have all found that testing is easy to do, effective, and works. So how do you get this sort of testing paid for? Because that is the other question. If it works and it's efficient, how do you get it paid for? So what I'm showing you here there are 4 different programs. And I'm going to focus on the largest program because this is the one with the largest school choice and lasts the longest through July 2022. And this program is it was the first allocation of monies from the Rescue Act. and it allows individual states, schools, and districts to choose the kind of testing they want to do. All 50 states, 5 large locals, as well as territories were given money from the federal government. It was deposited on April 9th of 2021. And you can see here how much money your state received as part of these funds available. This was critical because this is the money that was meant to be used and is being used for testing throughout the country. When you say, how do those funds get used? Well, this is that same data, but put onto a map. But importantly, on the right-hand side of the slide, 85% of the monies per the federal government need to be used for materials themselves, the test kits, the PPE, the direct staffing, and the services, including sample collection. 15% can be used for coordination and technical assistance. This is something very important. People perceive that the money can only be used for the tests themselves. It's not true. The federal government allowed this. It's also K through 12 schools, public, private, or charter schools. Now, each of the states might restrict that some, but very few, if any, of the states have restricted it. They've used mostly the same criteria that the federal government has used. And then most recently on August 10th, these monies can be used even to do community testing. And the few communities that have already started on that have found it highly effective. If you tell the parents they can come in and get tested alongside of their kids, so they see what's happening, they see how easy it is, they see it's not a tickle your brain swab, it's just the front little bit of the nose. We think that not only is it better infection control in a family, but it's the kind of education that makes everybody more comfortable with testing. Any percent of testing in a school is helpful, but ideally as high a number as possible. So as I conclude, and I'll hand it over to Rachel, I want to say that as strong as the vaccines are, and they are, no vaccine ever in the history is 100% effective. These are great and 90% plus, but not 100. We don't know how long they'll last. We know now that we're talking about 8 months, hence boosters. Not everyone will be vaccinated, we know, for all sorts of different reasons with hesitancy, and clearly right now, kids under 12, and the mutations can affect vaccine efficiency. So from my point of view, regular testing is essential to avoid outbreaks. We'll give you this presentation, but there are some informational sites that you can go to read up more and look at specific examples of testing that has worked in your community. Thank you very much. And I'm excited now to pass it over to Rachel, the Senior Director of Genetic Sciences at Thermo Fisher. Rachel?
Thank you, Mara. Thank you. Thank you for providing that great context as to why school testing is so important. So I wanted to provide a little bit more information about setting up a coronavirus testing program in schools. So first, a little bit of information about Thermo Fisher Scientific and our involvement in coronavirus testing. So we've been a global leader in COVID-19 testing from the beginning of the pandemic. We do over 50% of COVID-19 testing is performed using our various different technologies. Mara mentioned the different types of testing modalities that are available. We can manufacture around 25 million COVID-19 tests per week and can scale appropriately. If you look at the right-hand side, you see we're a pretty large company with $30 billion in revenue, 80,000 employees, and we invest about $1 billion in research and development per year. So that's allowed us to really be able to develop a very secured supply chain for COVID-19 tests and also continue to innovate around testing solutions for coronavirus testing. If you go to the next slide, as you heard from Mara, a regular and established testing program is really essential in helping to reduce school infection rates. And the good news for schools is that it's very straightforward to establish testing. First of all, funding is available, as Mara had outlined.
Secondly, guidelines have been well established. Mara brought up the K through 12 National Testing Action Plan. So there's a set of very solid guidelines in place already. And then, as I mentioned on the last slide, there's been a number of innovations around testing to where we can set up a program that is very minimally disruptive to the schools. So if you go to the next slide, a couple of factors really in looking at this and setting up a school testing program. First is that you want to make sure you have an accurate testing program, and that's really important for several reasons. You want to avoid having false negatives, and this is a situation where a person tests negative, but they actually are infectious and can then continue to spread the virus around the school environment. The other situation is false positives, where somebody tests positive where they're actually negative. And in that case, that may lead to unnecessary quarantining. So very important to have an accurate testing program, but also, especially in the school environment, you want something that's easy to implement and that's as least disruptive as possible to the classroom. So next slide, just kind of taking those considerations under advisement. First you want to think about the confidence in results. So, what accuracy is important. And this comes down to when you're choosing the testing modality that you're going to use in your school system, what type of test you would want to put in place. Second is what type of testing volume are you going to have in your school and how to set up the testing station so that you don't have a lot of disruption. Third is time to results. How quickly the results are needed is going to impact what kind of test you set up as well. And then the resources and expertise that may be needed both on site and with a partner in order to be able to set up a testing program. So if you go to the next slide, I just wanted to spend a minute talking about our Ready, Check, Go testing program. This is something that we at Thermo Fisher Scientific have developed in conjunction with Color Health. This is a comprehensive testing solution that really manages the entire process of testing from initial setup to results reporting, so that at the school there's as little to worry about as possible. So from setting up the program in the schools to establishing testing stations at school, the sample collection setup, shipping the samples to testing labs if that's necessary, reporting back of results. And so that's all part of the testing program that can be easily set up in the school environment. If you go to the next slide, this is just going to give an example. So, there are schools that may be concerned about the process and how it's set up. So this just gives you an example of really how easy it is to set up and how easy the swabbing process is. So if you can just play on that. So you can see here that you can actually set up a testing lab in the classroom. It's a short nasal swab, as Mara had indicated, as opposed to a long swab that just goes into a tube, gets sealed up, gets shipped out, and results can be back even within 12 hours in the school environment for a PCR-based test. So really simple to set up and very simple to actually run in the school, and students and staff can really easily administer the testing on their own. So if you go to the next slide, this is just a summary, if you just go one more slide, of the benefits of this type of program for school. First of all, there are a number of testing modalities available. As Mara mentioned earlier, pooled testing is a way to test multiple samples at once, but also individual testing, rapid testing. Those are all different modalities that you can get in a program like this. Very easy to implement. There is all the materials that are needed to set up the program. Fast sample collection, as you saw, it's just a short nasal swab that's swirled around a couple of times in each nostril, and then test results can be provided from a lab within 12 to 48 hours. And again, with the funding available, there's really little to no cost to schools in an end-to-end solution like this. So finally, this is just a great way to keep schools on track for in-person learning by having a regular testing program, and we've tried to really establish something that can be implemented very easily in schools. So with that, the next slide just has a QR code. If there's any more information that you're interested in, we can get somebody in contact with you to help you understand how to set up a program like this within your school or within your district. And finally, I just want to thank you for the time today, and hopefully this information has been informative. Thank you.